Welcome back to our third and final panel on education in Hudson County. Let me introduce our panelists from the left. Arlene Simon, you're the Chief Information Officer and I think Director of Business Development too for the Horizon Health Center.
COO.
COO, okay. Dan Altilio, who is the President of United Way Hudson County.
Correct.
And Susan Walsh. And Susan, what's your title now?
I'm the ACO Medical Director for Jersey City Medical Center.
And a former Deputy Commissioner of Health for the state of New Jersey. And those of you who follow the council may know that Sue was actually a panelist on our first State of Health, New Jersey State of Health in 2011. So nice to have you back. You're an alum panelist. So we've had a fascinating discussion this morning looking at the economy, at education, and now at healthcare in Hudson County. And as we go through, we can see that there's a relationship. Everything is linked, is interrelated. The last discussion that we had, especially on healthcare and education, would have linked terrifically to healthcare because they're so closely related. Let's start perhaps by just taking a quick read on, when you look at Hudson County, what are the biggest issues that you see facing the county? And Arlene, let's just start with you, go down this end. Your Horizon Health Center is a federally qualified health center.
Horizon Health Center is, as you say, a federally qualified health center, and we are primarily located in Hudson County, Jersey City and Bayonne presently. We have 2 locations in Jersey City. Horizon Health Center basically is a safety net facility, and what that means is that for the uninsured as well as the underinsured and the insured, Horizon Health Center is a welcoming facility that accepts every insurance, and we work with you. We're not free. We slide based on your economic status. So in some instances, you may qualify for zero billing, as well as in some instances, you will qualify for minimal billing. That said, currently in Hudson County, primarily Jersey City, the Bayonne locations, we have had some changes in the status of the hospitals. We are now fully located with 3 private hospitals and 1 hospital that is part of the Liberty Health System. Currently, the challenges we have, like every place else, we have a shortage of primary care doctors. We have a shortage in terms of certain specialties. One of the challenges we have, pediatrics. As you know, in many instances, some hospitals are closing and directing ped services to children's hospitals. That presents a great challenge for the people of Hudson County and Jersey City in particular.
Okay, great. And Dan, from your perspective as president of United Way?
Well, United Way works more generally, so we might be someone who could give a perspective from the outside who knows a little bit about the different silos. But first and foremost, Hudson, and I know everywhere in the world everyone thinks they're unique, but Hudson truly is unique in the fact that every bed demographic there is exists here at one time. We have the most densely populated cities in the entire country. 3 of them are in the top 10. Guttenberg is #1, and Union City is #2, and Hoboken is in the top 10. This is nationally. We have over 55% of our households speak a different language at home. We have the rate of infant mortality is very high. Literacy rates, and it's really very, it tells a story. I mean, we have for many years we had the #1 high school in the state, public high school, but at the same time, the other high school has a 50% dropout rate.
What was the highest?
It was McNair.
Which is where?
I believe it's on Brunswick or downtown.
In Jersey City.
Jersey City, yep, downtown. We also have major issues with immigration, people who are not documented here in our community. And unfortunately, all of that plays into the state of affairs. My area more, to have a little more perspective on it is around services for the homeless. And it could be categorized under behavioral health.
And child wellness, you focus on child wellness extensively.
Yes, absolutely. And the whole thing that we see going on in Hudson County with all of those gigantic issues, we have the hospitals in the last 3-4 years went from being private to public to private, and as each one of them went to become a private hospital, more and more people were not served and cannot be served, and that puts more pressure on the FQHCs as well as medical center or standalone.
Now, we still have the law in New Jersey that anyone who visits an emergency room has to receive medical care.
Correct.
So when you talk about the lack of service or the inability to really serve a community adequately, what beyond emergency room care? It's
beyond emergency room care. And even emergency room care, you know, you cannot discharge someone into homelessness. And so they'll do anything not to have them be a patient if a homeless person hits the system. And Medical Center, if I'm not mistaken, had one client who could have been discharged, but because he had special needs, and our shelters do not accommodate that, he was actually in the hospital for over a year.
Wow.
And if you add up the amount of money by not treating the system, as opposed to what it would cost to treat the person, it's just amazing, and the public does not realize that. So we have all of these things coming at us all at once in Hudson County.
And here to speak for the hospitals, Tell us about Jersey City Medical Center.
Actually, I think just listening to my fellow panelists talk, it's what makes it so much fun and so exciting to work in Hudson County. I know both these people, and they are passionate about solving the problems. And if we can solve it in Hudson County, we can solve it anywhere. You know, we have a very diverse population. We have very wealthy people in Hudson County. We have very poor people in Hudson County. And the fact that we have 3 FQHCs, that we have private hospitals, and we have the public hospital and the safety net hospital, Jersey City Medical Center, means that, and we have a source of primary care doctors and specialists here. If we can figure out how to do it in Hudson County, we really are the model for the country. And I absolutely believe that we're very far along that road of actually doing that. Jersey City Medical Center remains a not-for-profit hospital. It is the safety net hospital for the county. We are bursting at the seams. I think anybody who's visited our emergency room or has gone to any of our outpatient facilities can see that. We are absolutely committed to being here forever. We've been here for over 100 years, and we're not going anywhere. So as any new problems that come, along with my partners in the FQHCs and the charity organizations here in this city, Jersey City, as well as in Hudson County, we're just going to make solutions. And one of the solutions is trying to take a look at healthcare reform, which sort of part of that comes under the Accountable Care Organization. So the Accountable Care Organization is, with a leading facility such as Jersey City Medical Center, tries to create the kind of partners and networks where comprehensive care from cradle to grave, from door to floor to door, is completed so that everybody gets the best care necessary. And we bring the patients into it, which the FQHCs have been doing for decades now, the thought of the whole patient, what do they really need in order to manage their health? And they've been sort of our leaders in showing how that's actually done. And to bring that into a network of care so that wherever anybody starts the process in any of our facilities or with any of our organizations, they're cradled into this area where they have the best chance we know to have healthy outcomes. So I'm very excited, and I can hear it in their voices also.
So you are, Jersey City is an ACO.
Jersey City is creating an ACO. There are different definitions of ACO right now. There are some that are specific to the federal government, the Centers of Medicare and Medicaid services. There are some that are created sort of as networks or neighborhood, which is what we're doing right now, which is getting all the parties together so that we're ready for any health care reform legislation that will come under either this president or the next president. We don't sit still, so we are moving very fast and furious. And again, the difference between this health care and other health care, and I think you said it very well, we're not siloed anymore. Patients do not become hospital patients, doctor patients, nursing patients, homeless patients. They are a patient, and we are going to take care of them together. We're going to work together, and we're going to do it in a way that is the most cost-effective and efficient way possible. So, again, I'm very excited.
And that's great, because that's one of the things I really wanted to focus on was how has the Affordable Care Act impacted what you're doing, and we see your plans. And I know, Arlene, Horizon Health Center was the first FQHC in New Jersey to use electronic health records, is that
Yeah.
correct? And you
Yes.
are also a patient-centered medical home.
Yes.
Which for anybody who doesn't actually do a lot of work with healthcare, all of these initials are going to be very confusing.
Yeah.
So PCMH, explain the concept of PCMH.
The current definition of a patient-centered medical home, or in some instances, patient-centered health home, as some people define it, basically approaches that the primary care facility provider is at the center of the care. And the communications, the collaboration process, transfers around the primary care physician. The primary care physician acts as both the traffic cop, advocate, hand holder along the way.
The guardian, essentially, for the patient.
The guardian for the well-being of the patient in partnership with the patient. And in the PCMH model, everything that can be done at the primary care level has to be exhausted. You work within that system, you work to collaborate with the specialist, you work to collaborate with the hospital. As Sue attested earlier, we work with all of the hospitals. We work with Jersey City Medical Center, and in many instances, a patient will be discharged from the medical center directly to Horizon facility. We share the information, a document is transferred. The patient-centered medical care posits that we approach the entire life of the patient. We work with the whole aspect of it and share that information. If you can use that information to cut down on the replication of tests, and starting the process all over again when you go to another specialist, everything is visible. Horizon Health Center actually currently has a portal that we use for both patient, and we have one that we use for providers. On the provider portal, as opposed to waiting to share or fax that information over, you can share that information real time. What we found is that it cuts down on repetition. It allows for information to come back real time, so the medical assistant or the doctor isn't looking for a lab result when it resides there. That information is then imported into the patient chart. So you have a technology process supporting a process now, the workflow process, as it were.
And that's the whole concept of affordable care, really, is that we're supposed to be providing better patient care by reducing duplicative costs in the system.
Duplicative costs, as well as actually supporting the physician and the staff with ready access to information. The information will not make you a better doctor, but the way you use that information, it is hoped that there will be better outcomes for the patient. If you're a good doctor, you're a good doctor. If you're a bad doctor, the technology just makes it more obvious. But,
which is maybe a plus for the patients too. You know.
Exactly.
So Dan, from your perspective as somebody who's ministering to the county in a broader area than healthcare, but do you see the Affordable Care Act and healthcare in general, do you see it improving for the lives of the people that you're dealing with?
I feel that in Hudson County, again, the circumstances are such that we mentioned about the economic.
Right.
And, you know, for the national model to work, your facilities and hospitals have to have a mix of funding coming in, not just charity care and not, you know, just the high end. And everyone looks at Hudson County, look at that Gold Coast, how wonderful. Those people are not going to our hospitals. They are not staying here, they're not investing in the community. We have the highest child poverty rate in the state, highest poverty rate in the state, and that includes the salaries on the Gold Coast. So the model might be a good step in the right direction nationally. We're still in, you know, healthcare triage in Hudson County. That's the best way I can explain it.
Right. You know, we see this in every county we're in. You've got this disparity in every county. You've got an incredibly high-income place where everybody wants to live, the desirable zip code, and then you've got something that's just economically, you know, despair. So Hudson County, in that sense, isn't different than the rest of the counties. But I think maybe the Gold Coast, the positive impact, I mean, that's relatively recent in Hudson County, correct? In the last decade?
Yeah, 20 years. Yeah.
20 years, yeah.
Yeah.
So you don't see much integration then of that into Hudson County, the economy, which obviously is the basis for education, healthcare, everything else.
What I see is that, you know, in other well, first off, Hudson County is the only county without suburbs. So
Right.
just wipe that off the demographic.
Right.
If you go to other places, such as Bergen County, where there are communities with very high-end incomes, in Bergen County, those people are from the area, grew up in the area, and they continue to live in the area for the most part. Hudson County, the Gold Coast, the average is 5 years. And then you're out. They're not from here, they're not staying here, they know it, and now we're starting to get families stay a little more than in the past. But, and even so, they work, you know, might be working in Manhattan or whatever, they still don't trust our hospitals as good as they are. And medical center is a fantastic facility. And, you know, our FQHCs, we have a couple because the need is so high. And again, so it's that economic mix that is really wreaking havoc in Hudson County.
So what are some specific health concerns for all of you that you see that might be really notable in Hudson County, in the populations that you're dealing with, specific therapeutic areas?
Especially for the poorest of the poor, you have, it's after the, and I'm not a doctor and I don't have a medical facility, but it's after the diagnosis and, you know, we have someone go in and they're living in a box and, okay, you have cancer, all right, where do we go for this medicine? Where do I send? I can't tell you how many people are calling up for prescriptions. So here's your death sentence, you know, go back to your box. That's really the strain. Then you have people who are non-doc. And one thing about Hudson County, we are all very concerned with those people. This is our county. You could play politics elsewhere. We have to take care of our people who are here. And so that strains the system because we do whatever we can. And maybe some donations might have to go to that first since it's not funded federally. So all of it really is a stressed system at this point.
And specific health concerns that you might see that might be more prevalent in Hudson County than in other counties? And so maybe you could speak to that a little bit.
Well, I think there's a lot of chronic disease, as you would expect. There's a lot of the usual garden variety, diabetes, hypertension, strokes, heart attacks, cancer, as would be in any kind of urban center. I know the community health centers and the hospitals have been very concerned about things like lead poisoning in children and making sure that nutrition is sound in children. So I absolutely agree that there are the poorest of the poor here. I do know concerns about the undocumented who are not part of healthcare reform, and I have no intention of ever being part of healthcare reform if we listen to the politicians. People are people. So both the federally qualified health centers and the hospitals always see people as just someone in need and someone who needs our help, and they've never been turned away and they won't be turned away. So that is a continuing pressure that we have to make sure we have a solution for. When we talk about the Gold Coast, clearly they have their own needs, and again, people are people. You know, just because you have money doesn't mean you don't have healthcare needs and they shouldn't be met. So I know that as far as Jersey City Medical Center is doing, we're trying to find out what exactly it is they do need and what will keep them here. We know things such as midwifery care, which is already at the FQHCs, is something that we want to take a look at. So we have new birthing options for the women who live in that Gold Coast. We want to make sure that their children have a primary care physician. Pediatrics is a question that all of us are sort of struggling with now, and we're taking a look at that. I know Jersey City Medical Center is, as part of this network of care, this accountable care organization, is trying to make sure that we have a lot of patient engagement, that patients will want to come to us, that they'll want to come to our primary care doctors, that they'll want to come to our community health centers. Safety net does not mean healthcare of last resort. It's actually where some of your finest board-certified physicians as a group practice are in any particular community, and certainly in Hudson County. So we take a look at the needs of our community. We see the needs very, very broadly. We are there for everyone, and we are going to make sure that we have a solution, or at least have something that will engage the patients to want to come to us and make sure that they become healthy. Because remember, a healthy population helps just not us. It helps the business populations, it helps the schools, it helps families, it helps this country. So we are, again, very excited about all the work that we're doing here, and again, with some of the great help that we're getting even on this panel.
Sue, I know you've dealt extensively with the issue of healthcare disparity in your career. You've got, as you said, the most diverse population anywhere in the state here in Hudson County. Country. So how do you deal with the issue? I mean, generally we think in healthcare disparities in terms of, you know, dealing with the African American population, the Latino population. Here you've got hundreds of populations, right? So how do you begin to deal with the language barriers, with the cultural barriers? I mean, how do you address those things?
Horizon currently serves, our last estimation, we provide care in about 24 different languages. And that means all of those resources have to be lined up and be made available to provide care in 24 different languages. We have become resourceful because it's expensive. We are staffed with a diversity of languages, so that helps to support that. One of the other things that it should be noted here, as I was on my way over here, Governor Christie recently renewed the uncompensated care budget, which I believe now stands at $50 million for the entire state.
Right.
The reality is that $50 million will be gone very soon, within the next 3 months.
Yeah.
We have over 21 federally qualified facilities that absorb the undocumented and uninsured. We do not discriminate, and because we do not discriminate, we have to provide the same level of care for everybody that walks in the door. We have to become resourceful. We have done that. We've partnered with the hospitals. We currently work with Jersey City Medical Center in several areas. One of the challenges you'll find at what I call ground zero in terms of the healthcare landscape is specialty care, as Dan was alluding to. Someone gets a diagnosis of cancer. We have a SEED program. SEED basically only pays for you to get the test. So you've gotten the test, and you have some certain types of cancer, be it breast cancer, uterine cancer, and that's what you got. You got a diagnosis. Now, where do you get care if you're uninsured? Or if you're a mother of 4 or 5 and you work at McDonald's or you work at Old Navy, and all of a sudden they don't provide you with insurance.
Right.
So you're making $21,000. Where are you going to go?
Dan, what do you tell the people you serve?
We just try to help in any way we can. We try because, again, we're not really funded by the government except for the programs that we have. So my funds have less ties to them. And so we try and make accessible prescriptions, et cetera, on an individual basis mostly. One of the other areas that seem to be very high for Hudson County is in the area of special needs and autism. And the diverse county that we have, to that point, we support very heavily the ARC of Hudson County because they are serving the Latino community. They're serving the non-DOC community in North Hudson. And there are some cultural issues when you have a child with special needs.
Absolutely.
And everyone thinks they're alone in it. And if you do not speak English, never heard of a system, come from a culture that you deal with the child at home alone, you think you're on an island.
Even identifying an
even
autistic child is more difficult.
And you know how important early intervention is. So that's why we really support the ARC with the Spanish-speaking population, especially in North Hudson, to act as a clearinghouse and give information and guide people to the right services.
Now, did I see that there's not a county office for special needs in Hudson County? Or how do you integrate with the county to deal with the special needs?
I personally do not. I know that they have a person
Social
working on
services,
it.
I would
Correct,
assume,
social
yeah.
services. And there is money that comes in and it's coordinated and, through the nonprofits, the RFP, it gets diffused out into the community.
Okay. Sue, we did this panel, 2011, over a year ago,
And we solved everything. So.
Well, and the Affordable Care Act was going to solve everything, right? So why are we still here talking about all this?
Well, I think you've already heard some of the reasons. It's a very, very large problem, and it costs a lot of money. I think that one thing that I always try to teach when I teach residents about where healthcare is going is if your goal is to provide more care for more people, it's going to cost more money. There's no way to slice it any way different than that. And even in that CARE Act, there's nothing that's taking care of the undocumented, which for the urban Northeast is, and for the migrant workers down south, we forget that it's not just urban communities that feel this. I also want to just add to what they're saying about the language. There's also cultural changes. Just because you speak Spanish does not mean that you're going to be able to engage with a person who speaks Spanish. There are many cultures in our community also.
Speak Spanish.
I think the other thing about the Affordable Care Act, while I think that it is always good to see a problem and try to solve it, I think that sometimes you have to make sure that as you solve it, that you are very, very careful to take each step and to not jump over to a new solution. So one of the things that I think the FQHCs and the charitable organizations have done very well is to catch their breath and to try to make a plan for how we're going to implement. That's why, again, safety net hospitals like Jersey City Medical Center do not wait for the rules and regulations to come down. That's too late. You know, you need to start now, and I think that's why we've done a lot of collaborations with the FQACs, while we're collaborating with our specialty doctors, with our primary care doctors, with our mid-levels such as nurse practitioners and nurse midwives. We intend to solve the problem regardless of what the coming regulations state. So again, I think a very, very important part about in Hudson County especially is we are not waiting to see where Affordable Care Act is going to go. We've decided what pieces of it work for Hudson County, and we're trying to put those pieces together right now while we wait to see what the future brings.
Sue, do you have this, and you may not be prepared with this, but do you have the statistics for the charity care costs at Jersey City Medical Center?
You know, actually, someone whispered them in my ear as I was coming, and I have forgotten them because I cannot keep numbers in my head, so I do not want to say what it is. I can tell you that although the charity care dollars are distributed across the state, a safety net hospital in an area like Jersey City, you never recover your cost. It's always a proportion of whatever it costs you. So that has to be held up by having a diverse population so that we can make sure that we have enough money to go on.
We were in Mercer County last week, Skip Semino at RWJ Hamilton Hospital, and he said that out of they're reimbursed $500,000 a year for charity care. They spend $6 million a year on charity care.
The numbers
So
are actually, the numbers really are incredible and phenomenal. And again, I think that some of the dedication you've always had for people who take everybody who comes in the door, regardless of whether there's a particular pot to pay them out of it, is what's kept the system going. I think the Affordable Care Act was to sort of say, it can't keep doing this. We need a process, we need a system. So while the system and process may not be perfect, it's what we have to work with. And I'm hoping that it'll start to improve care and start to improve the parts of it that have started to be tied together so that we really can do this comprehensive patient engagement medical care that we all would want for ourselves and our own families.
Okay, let's talk for a minute about the insurance exchange in New Jersey, which, as we know, has been delayed. Probably, the question is, you know, will it be enacted at all in New Jersey, or will the feds come in and do it for us in 2013, or will the governor sign the legislation and move it forward? And there's now a new bill, I think, that Assemblyman Conaway has put forward. If the health insurance exchange is signed into law, clearly a large number of people have access to insurance who haven't had it before. Are we prepared for those people? Will that solve the problem?
Well, I think really that's what Arlene was talking about, is the primary care solution. Everyone who comes into a healthcare system needs to begin at the primary care level and not at the level of the emergency room or not at the level of a cancer diagnosis that now needs to find some specialty care. So yes, an insurance exchange that brings more health insurance to more Americans. Again, the question becomes affordability. The question becomes, what are the essential benefits? Can we agree on those so that if you're going to purchase a policy, that this is what you're going to get? And then once you do have that insurance policy, is there a doctor around to see you? And I think those are all questions we continue to struggle with. But again, we don't wait. You know, we're already trying to put those things together. I know with our residency training, and we have 53 internal medicine residents and many OBGYN residents also, we're trying to teach them how to use some of the new technology that Arlene talked about so well, how to use some of these new ties and collaborations so that maybe a single primary care doctor will be able to have a larger panel of patients because they're using more team medicine. They're using more mid-levels. They're using more nutritionists. They're using more therapists so that they can actually manage a team in a team approach, and the patient becoming a very important part of that team so that they can begin to manage their own disease also, to know what their blood pressure is, to know what their finger stick glucose is if they're a diabetic, to know what their exercise prescription is, to know what they need to do so that we can kind of leverage those dollars in a way that lets us provide more care. But again, more care for more people costs more money. And as safety net providers, we're very, very aware that already there's not enough to do everything we want to do. So we're watching it very carefully.
Let me ask both of you, do you see if we had an insurance exchange, if we had one in place now, which theoretically we could have had, would that have an impact on the populations that you see?
Yes and no. And I'm glad Sue just did that. Our problems and our solutions are basically occurring in what I would call organic to your community. So there is no one size fits all.
Right.
So you get an insurance exchange. This morning as I was coming in and I scanned the papers, we now have a problem in New York where more and more doctors are not accepting insurance. And you are going to see that unless the payer, the insurance, makes an adjustment in the relationship. It cannot be where it's take it or leave it. These people have spent their lives working in a very strenuous environment to create a profession that is extremely unique. And to ask of them to make $1 million investment in their education and then come out and take it or leave it, I'll give you $12 for a visit.
Right. That's really a doc decision, not an insurance company
It is the insurance companies in some instances because the relationship, they haven't adjusted. So now, because of the changes in the Affordable Care Act, their leverage has increased. So the insurance exchange may or may not impact everybody. It may not be a positive impact for everybody. It may be a negative impact in some instances.
Do you see it overall as being positive or negative?
I see it overall initially as being positive for the whole community. If we can manage our costs, because some of the things that it forces us to do as institutions is to do it right the first time. If we can get to the point where we can do it right the first time, we eliminate that issue of more insurance, more service, more money. We could take one of those equations down a bit, the more money portion.
And do you see an actual savings? Because you've implemented electronic health records. Have you seen a cost savings, or is it too soon to tell?
No, actually, there's a misconception that you save money when you go into an electronic health record. When you go into an electronic health record, you're changing the culture of delivering care. You're asking professionals who have developed and honed their skills in one environment to enter into a new ecosystem and do things differently. So you stood there waiting on the chart and the MA scribbled the vitals and they walked over and you scribbled your Latin gibberish and you handed it over to someone else. That goes away and now everything is clearly in English and you look like you're an idiot because you didn't check this and you didn't check that. That adjustment causes doctors to slow down, causes nurses to slow down. Because all of a sudden you have all of these checks and balances.
So you're looking at a long-term, perhaps,
you
cost impact.
It's about process. If you focus on the fact that you're improving the quality of the process, you're bringing visibility, you're bringing information to the forefront. You are not look at the cost, which is very difficult to do. I have my CEO here, and she will attest to that not being the case.
We don't have a lot of patience in our culture for not looking at cost.
No, the cost keeps rising because you go from seeing 4 patients an hour maybe to seeing 1 because you're doing it in a different environment. So that immediate impact is not there in terms of just the cost reduction. But it is impacting, and because now we're sharing. We have programs that we collaborate on together. Our patients now see specialty because we collaborate with the hospital. Now, if you, as I just alluded to earlier, if you're a cancer patient with a diagnosis, you're not getting to see an endocrinologist. If you're not willing to hand over $300, or minimum. I'm just being very
sure. If you have to,
but in this new shared environment, because we have the collaboration. You will see that specialist maybe for $75 an hour. Maybe now, because of our partnership that we're working on, I have all these tests, you can see them right away, you don't have to replicate them. The hospital will be able to maybe work you into getting care at the Cancer Treatment Center.
And Dan, your patients, but your community, maybe health insurance is the least of their lack of health insurance, is the least of their problems if they're also homeless, if they're, would health insurance help? It couldn't hurt, I assume.
Health insurance will help, of course, but I think the answer that you're hearing, and it could be with the reform or without the reform, no one any longer has enough money to run their programs alone. And the market is pressing us to work together, break down the walls, because you call the person homeless, and in the child care community, it's aging out youth, and it's the same person. So we're working on stuff like that. And we've had a few different manifestations of that recently, one with the medical center. And so that's where it's headed. The other part of it also is that, you know, it's very difficult in this environment when everyone is stretched to the penny. How do we deal with prevention programs? You know, we're just going to sit here and just keep grabbing as things are falling.
Well, prevention and healthcare literacy,
Yeah.
because assuming that all these people can access the system,
Yep.
you know, a culture where someone has never seen a primary care physician in their entire life.
Right.
You know, they don't know how to call and make an appointment. They don't know when they're sick enough to actually make an appointment with the doctor. The concept of well care is probably totally alien, totally foreign to them. How do you begin to deal with now, what are our estimates in New Jersey? 250,000 possibly new patients, up to, I've heard up to 400, 450,000.
Things change.
Yes, new patients, yeah, it's a moving target, who may have access to insurance, but they have no education that lets them know how to become well or stay well.
Right.
You know,
Well, actually, one of the parts that I think, I know again the FQHCs have probably led the nation in doing this, is the whole concept of care navigators or care coordinators or case managers or whatever we want to talk about, where a patient, and this doesn't have to be a high-level education, this doesn't have to be a doctor or a nurse, this can be a very community activist, a community worker who understands the systems of care in their community, who can help guide people to exactly that question: when do I call the doctor? How do I get in a primary care physician relationship? When am I sick enough to go to the emergency room? And even more important, what can I do? And I keep coming back to this whole concept of self-management of the chronic diseases. What can I do that directly impacts how well I am and how much of the healthcare resources I need to have dedicated to myself, so that I can live a happy and healthy life, which is really all we want. We want to all be able to wake up in the morning and not hurt, and be able to function and to be able to do the things that we want to do. So what part of that piece do I own as a patient? And are there people who can help tell me and answer those questions for me, so that I don't go to the emergency room when I could have gone to a primary care doctor, so that I don't sit home and suffer when what it might take is a call to go see a primary care doctor or to go to the emergency room because it's an appropriate emergency room visit. So I think care navigators or care coordinators or whatever all the new terms are is a part of healthcare reform that began a long time ago, but they're becoming more visible. And the concept that resources should be spent around that level of care, I think, is another important piece of what we're all struggling to make sure that we have those kind of workers with us.
Yeah. We have just a few minutes left. Let me ask each of you if you could do the one thing that would bring about a healthier population in Hudson County in general. What would it be? What would it take to really make a healthier population here in this county?
Well, and it's going to be an unexpected answer. I think it lies in education. You know, I think the more that we can not just educate patients on how to manage their health, but the better educations we do in the Head Starts and in the kindergartens and in the grade schools, so that we get people out of the cycle of poverty, because there's no greater stressor to health care than being poor. So my money, I would continue it on the public education part, and in the meantime, I could use a lot of money for my safety net hospital also.
Dan, from your perspective?
More money for coughing.
I can fix that.
You didn't attach a budget to the question.
No, it's a magic
So
wand.
I will assume we're zero-based budget once again, unfunded mandate. But I really think along the lines of what you were talking about, a healthcare navigator available to everyone in every culture really will help the system. It could bring a lot of stress down on the system financially.
That's terrific. And Arlene?
I'll agree with Sue. I believe education is the key to getting us out of poverty and getting us into a much more informed self, you know, being able to have the information. One of the things that I found that was so surprising was how actively engaged our patients became once they discovered the portal. We went from having 125 patients turn on their portal, and now we're at 1,005 something the last time I checked. And what I found with those patients is that now they can go in, they have health education, they can ask a question, And because they're now getting responses, and this conversation has begun quietly, that isn't forcing them to walk into a facility, they're becoming more informed, more engaged,
Well, they're
and
empowering
making
themselves to do that.
They're empowered with knowledge. So whether we start at the school level or whatever, education, we have to do a better job. If we do a better job, people understand the stretch of the dollar, or what it doesn't do, what it does do. And if we can do that, I believe, and this is all about information, the health exchanges are not going to magically solve our problems. It's expensive. It's expensive to see an endocrinologist. It's expensive to see a primary care physician. Their time costs money. If you will stop drinking 16-gallon bottles of soda for breakfast in the morning, maybe you won't start out with, blood sugars of 200, and maybe we can get you down to 1 something. If I can get you to talk to a nutritionist, I want to understand your culture, what you consider a good breakfast in the morning. I may not consider it a good breakfast in the morning, but there may be options that we can work with. So a lot of it goes back to what Dan just said. If I can get a care navigator to talk to you as easy as possible. Do I talk to you on your phone? I think the biggest care navigator is in our pocket. Can I get you
Absolutely. Look how tied we are, how tethered we are
we're
to our
we're
cell
tethered
phones.
to our phones. And can I talk to you there? Can I ask you a question or two? And maybe I can answer those questions for you. And I think all of it, again, ties down to education.
Well, that's what the council is all about, and all three of you have really added immeasurably to our understanding of healthcare today. So thank you all very much for being here.
Thank you.
And thank you for joining us today.
Great conversation.